Welcome to the topic, drugs for respiratory disorders. So the respiratory system actually supplies the oxygen for the body and provides the protection against the inhaled organisms. So including the respiratory system, it's one of the most important organ systems. It filters the incoming air and provides the critical oxygen for cellular functions, the vessel for the body to rid itself of the excess acids and bases, and the process of the gas, oxygen, and the carbon dioxide exchange is known as the respiration in the respiratory system. So this is our respiratory system, and the process of the gas exchange occurs like that. So expired air comes out via alveolus, and the air that goes in is called as inspired air, which have the oxygen in it. So oxygenated blood circulated back to the heart, and the carbon dioxide with the deoxygenated blood from the heart goes back to the alveolus and comes out as an expired air. If we talk about the upper respiratory tract, which is including the nose, pharynx, and larynx, nasal cavity, paranasal sinuses as well, it warms, humidifies, and cleans the air, and it traps and removes the particulate matter and pathogens. Then the lower respiratory tract, the lungs and the associated structures like bronchi, bronchioles, and alveoli. Perfusion is the blood flow through the lungs, and the ventilation is the process of moving air into and out of the lungs. Inspiration and expiration occurs under it. Then we have the inhalational route that we use for the drug administration quickly that delivers the medication directly to their sites of action. The drugs, they have a rapid and efficient mechanism for delivering the drugs. They're almost instantaneous onset of action for the inhaled substances, and the medications are delivered to the respiratory system by the aerosol therapy. Primary goal is to keep the airways open always, and the drug delivery can be done by using a nebulizer or the aerosol. So first is aerosol. It's a suspension of a very small liquid droplets or the fine solid particles suspended in the gas. And then we have nebulizers. These are the small machines that vaporize a liquid drug into a fine mist that can be inhaled, often through a face mask. Then we also use some meter dose inhalers and the dry powder inhalers, which is called as DPI. This is a small device that is activated by the process of inhalation to deliver a fine powder directly to the bronchial tree. For example, turbohalers, discus, rotahalers, these are all the types of the dry powder inhalers. Then is the meter dose inhalers, as shown in here as an aero chamber with it. A third type of a device which is commonly used to deliver the respiratory medicines. Then the drugs used to treat the respiratory disorders, it's given over here. Number one is antitussives. Antitussives are actually just suppressing the cough. They are acting onto the medullary cuff center. Then we have the topical decongestants. As the name is decongestants, they're trying to dry the nasal mucosa. Then we use some mucolytics, which loosens the mucus. Lytics means breakdown, and the muco is mucus, so loosens the mucus. We have inhaled corticosteroids. They suppress the inflammation. We have some expectorants. They produce the thinner mucus. We have some mast cell stabilizers or antihistamines. They inhibit the histamine release. And we also use some bronchodilators. As the name suggests, they dilate the bronchi. So allergic rhinitis is characterized by sneezing, watery eyes, and the nasal congestion. All that includes the stuffy nose, dullness, and the headache as well. And what is the pathophysiology of the allergic rhinitis? So what happened? There is the first exposure to the pollen. When it is an exposure, then the plasma cell releases the antibodies in the body, and the plasma cell are releasing IgE, that is immunoglobulin E antibodies. These antibodies, they will bind to the mast cell, and the mast cell, the pollen, binds to the antibodies and causes the histamine release. And this histamine will cause the allergic symptoms, which causes the allergic rhinitis. So allergic rhinitis is actually happening exposure to an allergen. The symptoms resembles common cold, tearing eyes, sneezing, nasal congestion, post-nasal drip, and itching of the throat. So if a person complains about it, it has allergic rhinitis. problem is inflammation of the mucous membrane, and the treatment goal is preventers and relievers can be used. Then is antihistamines. They are widely used to treat the allergic rhinitis and other minor allergies. So selected OTC antihistamine combinations. For example, we find out in the market as a brand name Advil Cold and Sinus Plus. It has an antihistamine chlorpheniramine, decongested pseudoephedrine, and analgesic ibuprofen. Benadryl allergy or sinus, it has diphenhydramine, pseudoephedrine, acetaminophen. Dry oxyrel, cold and sinus, dexbro, brompheniramine, and decongestant pseudoephedrine. Benylin all-in-one, cold and flu, Claritin allergy and sinus, Dimetapp, and Dristan extra strength. So you will see in most of them, they have the pseudoephedrine as a decongestant and others have phenylephrine. Few of them have acetaminophen as an antipyretic effect as well. And some of them, they don't have acetaminophen, and other drugs, they are the antihistamines. So they all have antihistamine, they all have decongestant, but analgesic is in few of them. So it makes us to help choose better thing that what we need. Other than that, we have neocitrin cold and flu, Nyquil sinus, Reactin allergy and sinus, Sinutab nighttime, Sinutab sinus and allergy, Tylenol allergy. So we don't understand when we go out that which one to take when we are having allergies. So we have to see if we need antihistamine, if we need decongestant, or if we need the analgesic. So we will choose the products accordingly. Then we can also use some intranasal corticosteroids, which becomes the first line drug for the treating the allergic rhinitis. Also, the glucocorticoids is one of the corticosteroids. It must be applied consistently. They decrease the secretion of the inflammatory mediators. They reduce the tissue edema, and they cause a mild vasoconstriction. They can take 2 to 3 weeks of therapy before optimum benefits are attained. Consequently, most effective when taken in advance of expected exposure. When delivered by the oral inhalation, but not the intranasal, some of these medications are also used to treat the asthma as well. So then decongestants, they are used to reduce the nasal congestion. That's why we use, which is caused by the allergic rhinitis and also sometimes the common cold. They are the drugs like sympathomimetics. And what are the sympathomimetics? They are the agents that activate the sympathetic nervous system. They're effective at relieving the nasal congestion associated with allergic rhinitis and the common cold. Oral and intranasal, all the preparations are available. Rebound congestion is also occurring by them. They're limiting the adverse effect, and their prolonged use causes the hypersecretion of the mucus and worsen the nasal congestion once the drug effects wear off. So decongestants also have a side effect of the rebound congestion. Rebound effect sometimes leads to the cycle of increased drug used as a condition worsen and should be used for no longer than 3 to 5 days. We also use some antitussives and expectorants, as we see that in the chart. They're used to treat the symptoms of the common cold as well. So antitussives can be categorized into opioids, which act by raising the cough threshold in the cough center. They decrease both the frequency and intensity of the cough. Non-opioids like dextromethorphan, they're chemically similar to the opioids, acts on the CNS to raise the cough threshold. We use benzonatate, Tesalon. It comes in capsules. They look like this. They has the local anesthetic-like effect on the stretch receptors in the lungs, which essentially interrupts the cough message. We use the expectorants, which are the drugs that reduce the thickness or viscosity of the bronchial secretions. They stimulate the mucus flow, which thins the bronchial secretions, allowing them to be removed with less forceful coughing. And the example is the guafencin or the Mucinex. Then mucolytics can be used. They directly loosen the thick, viscous bronchial secretions by breaking down the chemical structure of the mucus molecules. And we use the drug, which is acetylcysteine, also called as the mucomist, which is delivered by the inhalational route and is not available OTC. It is used in the patients who have cystic fibrosis or other diseases that produce the large amounts of the thick bronchial secretions. It is also given as a 5% oral solution for acetaminophen overdose. Then comes to the asthma. So what is asthma? It is a chronic inflammatory disease which is characterized by the bronchospasm. Chronic inflammation that occurs when the potent mediators of the immune and the inflammatory responses are released by the mast cells lining the bronchial passageways. Mucus secretion is increased, which narrows the airways and makes the breathing more difficult. So these asthma components includes the bronchoconstriction, in which the smooth muscles contract, airway diameter narrows. Inflammatory condition make the smooth muscles hypersensitive to stimuli. And what are the stimuli? Like the smoke, pollutants, or the cold air, which are the possible triggers of the asthma. So normal bronchiole looks like as in an A picture. And when in the mucous membrane, the airway, the smooth muscles are going and the asthma attack occurs, this inflammation occurs in the middle, we can see, or the bronchoconstriction occurs. So if inflammation is there, then inflammatory cells in the debris fill the airway. And if it's a bronchoconstriction, then the smooth muscle contraction constricts the airway. So there are common triggers of the asthma: air pollutants, tobacco smoke, ozone, nitrous and sulfur oxides, fumes from cleaning fluids or the solvents, burning leaves. Allergens, they are pollen from the trees, grasses and weeds, animal dander, household dust, and the mold. We use some chemicals in foods like the drugs such as aspirin, ibuprofen, and beta blockers, sulfide preservatives, foods such as nuts, monosodium glutamate, MSG, shellfish, and the dairy products. Some respiratory infections also triggers the asthma if you get a bacterial infection, fungal, or a viral. Stress, it's emotional stress or anxiety gives you asthma attack, and exercise in a dry and a cold climate will give you some of the asthma attacks. The symptoms includes the evening cough, dyspnea, which is the shortness of breath, chest tightness and wheezing, bronchoconstriction and bronchospasm. And when it is a status asthmaticus attack, it is a severe attack which prolongs the form of the asthma, unresponsive to the drug treatment, and it may lead to the respiratory failure. So beta adrenergic agonists, these are used as the most effective drug for relieving the acute bronchospasms. And the drug classes used in the pharmacotherapy of the asthma is either they are using for the termination of acute bronchospasm, which includes the SABA, that is short-acting beta-adrenergic drugs, or anticholinergics and xanthines. If it's a prevention of the acute bronchospasms, we will use inhaled corticosteroids, anticholinergics, long-acting beta-adrenergic drugs, mast cell stabilizers, and also the leukotriene modifiers. So these are the categories of the drugs classification that we use for the asthma treatment. Then beta-adrenergic agents causes bronchodilation. They engage the sympathetic nervous system. One is the short-acting beta agents. They're most frequently prescribed drugs for the aborting or terminating an acute asthma attack. And why? Because it begins to act within minutes and it lasts only for 2 to 6 hours. So when we talk about long-acting beta agonists, if it's long-acting, absolutely, it's going to take 20 to 60 minutes to act. Not used to terminate the bronchospasm. It is used always in a combination with inhaled corticosteroids for the prophylaxis of the severe persistent asthma. Then we use some corticosteroids. They are the most effective drugs for the long-term prophylaxis of asthma. Corticosteroids are not for immediate relief. They must be used on daily basis and the symptoms improve 1 to 2 weeks, 4 to 8 weeks for the maximum benefit, and they suppress the inflammation by mucus production, and edema are diminished in this and reduces the airway obstruction as well. So the drugs that we use here is the mast cell stabilizers also and leukotriene modifiers. So mast cell stabilizer is a cromolyn sodium and leukotriene modifier is a montelukast, which are anti-inflammatory drugs used for the prophylaxis of the asthma. So mast cell inhibitors, they inhibit the release of histamine from the mast cells as the name suggests, and they are safe alternatives to the glucocorticoids if we don't want to give any steroids to the patient. Leukotriene modifiers, they reduce the inflammation, they ease the bronchoconstriction. They modify the action of the leukotrienes, which are mediators of inflammatory response. They're used for the management of the persistent asthma that cannot be controlled with inhaled glucocorticoids or the short-acting beta agents. Then is another one is the chronic obstructive pulmonary disease, COPD, which is a progressive disorder treated with the multiple drugs. So the chronic obstructive pulmonary disorder or disease, It is a chronic bronchitis and emphysema. Its a primary cause is tobacco smoking, major cause of the death and disability, progressive disease, and can treat only symptoms, not a cure, and the number of pulmonary drugs used for the symptomatic relief in here. The goals of pharmacotherapy becomes we treat infections, control the cough and bronchospasms, and the drugs used are the bronchodilators, beta-2 agents, inhaled glucocorticoids, mucolytics, expectorants, and we use the oxygen therapy as well. So the drugs they are used for the disease for respiratory systems are anticholinergics, bronchodilators, which is beta-adrenergic long-actings, and bronchodilators, beta-adrenergic short-acting. We use some decongestants here. H1 receptor blockers, which are the first generation antihistamines, which ends with the phenyramine or hydrinate hydramine. H1 receptor blockers, which are the second generation antihistamines. Then we have the inhaled corticosteroids. Then we have few of the intranasal corticosteroids, leukotriene modifiers, mast cell stabilizers, and the xanthines. So in the respiratory system, we understood the respiratory system supplies the oxygen and protection. Inhalatory drugs are distributed directly to their sites of action. Histamines, corticosteroids, and decongestants, they treat the symptoms of allergic rhinitis. And the common cold is treated with antitussives and expectorants. The bronchospasm of asthma is treated with the beta agonist and corticosteroids, mast cell stabilizers, and leukotriene modifiers. And the symptoms of the COPD, chronic obstructive pulmonary disease, they are treated with the multiple of the drugs. Thanks for watching.